minutes and then we'll get started.
Great. I mean, we're all set, right? I don't have to do anything except wait for you to finish your introduction and then I'm off.
You got it. And you know how to advance your slides.
I do.
They look fabulous there. And then at the end, I'll moderate the questions, just feed you the questions, and you can kind of go from there.
Perfect.
Just give it like one more minute. Let some people run in from their morning clinics.
I'll at least have some people signed up, so that's good.
Oh yeah, yeah. So usually the names on the list of participants usually represents a group of people. So
Okay.
when we've pulled the fellows before, it's about an average of 2 to 3 people on at each one of those sites. So if you sort of multiply that number by 3, that's who you're looking at. And in general, we feel like there's about 70 people who watch each time, which is not bad. Represents maybe a third to a quarter of the fellows.
No,
And
that's fabulous.
considering that this is noontime Eastern and 8 or 9 on the West Coast, it's middle of clinics and all that. I think it's worked out pretty well.
How many of these have you done so far?
This is 108.
The 108th? Wow.
Yes.
That's quite good.
It's all because of you guys who have volunteered to speak.
Well, I am delighted to be a part of this.
Well, I think we'll get started here. I've got a little bit afternoon. Good afternoon, everyone, and welcome again to another in the SMFM Fellow Lecture Series. My name is Bill Goodnight. Thanks, everybody, again for joining in. Today, it's my pleasure to introduce Dr. Richard Berkowitz from Columbia University. He's professor of obstetrics and gynecology. And our lecture today in our core series is on neonatal alloimmune thrombocytopenia. I think this is a fabulous lecture, confusing for all of us who don't see it very often. So I'm very happy very happy to have Dr. Berkowitz today to lead us through this complicated clinical issue. Dr. Berkowitz, thanks for joining us.
Oh, thank you. It's a pleasure to be here. Good afternoon to all of you on the East Coast. Good morning to those of you in the rest of the world. Before I start this, I just want to say that I have 2 objectives in this talk. The first is what the billing of the talk is actually all about, which is to try to talk to you about the diagnosis and management of alloimmune thrombocytopenia. But the second objective is to share with you my own personal experience with this disorder. Because I think it is an illustration of a different way to do clinical research that's a bit outside of the standard way of doing large clinical studies. So I'll try to deal with both of those things and try to turn this into a story as to how we got to where we are today in terms of our approach to this disorder. So with that in mind, let me begin by talking to you about how it all started. I came to New York City from New Haven in 1982. And I went to Mount Sinai Medical Center, and I was one of a fairly small number of people around the United States who at the time could do fetal blood sampling. And as a result of that, our department and division at Mount Sinai became a place where women were referred who had significant problems with Rh disease. And we were doing intravascular transfusions on those fetuses, and were at the time the only place in New York City and in the New York metropolitan area who did that. And one day I got a phone call from a pediatric hematologist at Cornell, whose name is Zell, and this is what he looked like back then. This is what he looks like today, and I think you can see that the years have been pretty kind to him. And he called me up and said, I'd like to talk to you about collaborating on working with the diagnosis and hopefully management of alloimmune thrombocytopenia. And I said, that sounds very interesting, but I have no idea what the disease is. So he gave me a bit of background, and that I will share with you now. He told me that this is essentially the platelet equivalent of Rh disease. This is a disorder in which women create antibodies to antigens on their fetal platelets, not on their own platelets. And those are IgG antibodies which cross the placenta, attach to the fetal platelets, and those platelets are subsequently destroyed by the fetal reticuloendothelial system, resulting in significant thrombocytopenia. And that, of course, can be associated with bleeding problems in utero. It's a relatively rare disease. The incidence depends on the actual population you look at, but it's stated as being somewhere in the neighborhood of 1 to 1,000 to 1 in 5,000 live births in the United States. Without question, there are many human platelet antigens, but the one that is the greatest offender in this disorder, without question, used to be called PLA1. It is now referred to as human platelet antigen, or HPA1A. That is the antigen that causes the majority of problems that we see with clinical cases. The majority of the population in the United States do not have this antigen. So approximately 2% of the population in this country is PLA1 or HPA1A negative. There are a bunch of other antigens that can cause this problem, but they are not nearly as numerous or cause problems that are as severe as the HPA1A antigens. Unlike Rh disease, this is a disease which can affect primiparous women in their first pregnancy. I'm sure you all know that in Rh disease, it rarely affects first pregnancies and tends to get worse in subsequent pregnancies. In this disease, it can be very bad in the first pregnancy. It can get a lot worse in a number of these patients. And if you have an affected woman who has an antigen-positive baby in the next pregnancy, it is virtually 100% certain that she will be affected in the next pregnancy. If you don't treat this disease, the babies are born with extremely low platelet counts. In fact, it is the most common cause of severe thrombocytopenia in neonates. And of great importance is that somewhere in the neighborhood of 10 to 20 to 30% of these babies will bleed into their brains. And about half of those cases can occur prior to the onset of labor. So that the strategy of just saying, okay, we have an affected fetus, we'll deal with this by just doing an early elective cesarean section, will not save a number of these babies from getting into trouble before you do that. They can have other hemorrhagic complications, and typically, well, some of these babies are born with absolutely no clinical indications of disease, and you only find out about them if there has been a CBC ordered on them, and you see that, or the neonatologists see that the platelet count is low. But clinical manifestations start with petechiae, like you can see in this slide, and this is relatively minor petechiae. I'm sorry, I went the wrong way. That is far more significant petechiae, but the thing that we are of greatest that is of greatest concern is when they bleed into their brain and have intracranial hemorrhages, which can cause death in utero, or perhaps even more significantly, significant irreversible long-term impairment. So this is what Dr. Bussell told me, and I said to him, well, thank you for all of this information. I've been educated, but why did you call me? And he said, well, because I had a case that I want to share with you. And this is a woman who herself was a physician, is a physician. And in her last pregnancy, she delivered at 38 weeks, and her baby had a birth platelet count of 3,000, virtually no platelets. And that child died on the first day of life. And a scan that was performed before it died, as well as an autopsy that was performed after it died, revealed that this child had a massive intracranial hemorrhage, which they thought had occurred at about 32 weeks, 6 weeks before her delivery. That patient came to Jim, a pediatric hematologist, talked to him about the case, and because he had taken care of babies with this condition after they were born, and he said, well, one of the mainstays of treatment of these babies is to give them IVIG, intravenous immunoglobulin. Why don't we try treating you in your next pregnancy before you deliver? He did that, giving her treatment at a gram per kilo per week. Plus, he treated her with dexamethasone at a very high dose. And the bottom line is that that baby delivered with birth platelet count of 30,000, did not have an intracranial hemorrhage. And that child is now alive and well at about 31 years of age. And so what Jim said to me was, I would like to collaborate with you because I would like to study the natural history of this disease prior to birth. I would like to try to help figure out the optimal therapeutic approach to patients at risk to have this problem. And both of those things require fetal blood sampling. In addition to that, these women, when they're pregnant, are going to be will need to be managed by an obstetrician, so I need to have someone to work with. But perhaps most importantly, I need you to get other obstetricians to send us patients, because this is a rare disease. And if any one person tries to do this by themselves, they're never going to see enough cases to be able to make any progress with this disease. And so that's why I would like to collaborate with you. We could give IVIG, we could give it at the dose I gave, but it's expensive, and it's not a good idea to give more than we have to give. I'm not sure whether we need to give steroids. Both of those things can cause adverse effects on the mother. But if we undertreat, we won't accomplish our objective of trying to avoid getting intracranial hemorrhages. So we have to do fetal blood sampling. And the reason we have to do fetal blood sampling is that there is no biomarker for fetal blood for fetal platelet counts. We have to get fetal blood and actually do a fetal platelet count in order to see where we are. And that's critical to know for all of the studies that I think that we'll have to do to try to answer the questions that I've posed. Now, just to remind all of you, fetal blood sampling is not a benign procedure. It's associated with all kinds of potential complications, and they're listed on this slide, and you can see what they are. So this is not something that you want to do if you can avoid it. But the reasons for wanting to do fetal blood sampling in studies connected with alloimmune thrombocytopenia are listed on this slide. To begin with, you have to know what the platelet count is before you start in order to know that what you've done has made a difference. How do we know that that woman that Jim treated for the first time, who delivered with a birth platelet count of 30,000, had a very low platelet count at the beginning of the pregnancy, and that we in fact had accomplished anything? We'd also like to know what would happen to fetuses that get sampled early in pregnancy and have a perfectly good platelet count. What happens to them if you don't treat them? When do you need to start to think about treating them? Also, if you are treating, how do you know that what you're giving is doing what you want it to do? How do you know that you're treating with the appropriate amount? And finally, if these patients are going to deliver vaginally, how do you know that the fetus has a good enough platelet count to allow them to undergo what is in fact a potentially traumatic trip for the fetus through the maternal pelvis if it's got essentially no ability to clot? How can you avoid getting intracranial hemorrhage at the time of delivery if you don't know the platelet counts? So those were the reasons for doing fetal blood sampling. So we did a number of randomized trials, and the first one was published in 1996, but I'd like to just talk a little bit about how we organized this. What we did was to get IRB approval to do this study at both New York Hospital, at Cornell, where Jim was, and at Mount Sinai, where I was. We got FDA approval to give IVIG to these patients. It was for an unapproved indication, and we got an IND for that. We then sent out letters, and this was in the 80s, so this was before email. We sent out letters to all the MFM doctors in the United States telling them what we were interested in doing and asking them to recruit patients into our study, and gave them our study protocols. Then whenever they had a patient, that patient entered in, they needed IRB approval at their own institution, and we sent them a template for how to accomplish that very easily and expeditiously. Patients in the studies, wherever they were being studied around the United States, signed consent prior to getting IVIG and being randomized, and they all got all signed consent prior to having fetal blood sampling done if they were done locally. Some of the patients came to New York to have the blood sampling done here. Some of them were in the New York metropolitan area, but many of them were sampled in the place where they were getting their obstetrical care. And the design of this first study was to do an initial blood sampling prior to starting any therapy to document that the fetuses were thrombocytopenic. We then treated them with IVIG at 1 gram per kilo per week, plus randomized them to receive dexamethasone at a low dose of 1.5 milligrams per day or not to receive dexamethasone. We then repeated the fetal blood sampling 4 to 6 weeks later. If the response was considered to be adequate, we didn't change their therapy. If it was inadequate, we added prednisone at 60 milligrams per day, or delivered them if they were late enough in the pregnancy to have that as an option. And finally, if they wanted a vaginal delivery, we did blood sampling at 34 to 36 weeks to see if the platelet count was good enough to warrant a delivery, an attempt at a vaginal delivery. So we had 51 patients all together in 17 places around the United States and in a couple from the Netherlands. And you can see by looking at this that at the time of our first blood sampling, the platelet count was in the low 30s. It essentially doubled after 4 to 6 weeks of therapy and was essentially tripled at the time of delivery. There were no intracranial hemorrhages, and none of them had any problems related to the blood sampling in this first study. We also found that if the initial platelet count at the time of our first sampling was greater than 20,000, almost 95% of those patients responded to the initial therapy. Whereas if it was less than 20,000, less than half did and needed augmentation. The other thing I'll mention is that the dexamethasone at the dose we were giving it made no difference. So adding the dexamethasone at that dose didn't make any difference. So the conclusions from that initial study was that IVIG, with or without dexamethasone, will give you a platelet count of greater than 30,000 in almost 3/4 of the cases. However, you needed to increase therapy by adding what we called salvage therapy with prednisone to get the success rate up to 80%. And that the failure rate using IVIG alone is going to be higher if the initial platelet count is very low. Now another thing, and then we looked at natural history of alloimmune, and this was something that was published the following year. We looked at 107 patients that had fetal blood sampling and found that in half of those cases, the initial platelet count was quite low. And when we looked at 46 cases in which the initial sampling was done at 24 weeks or earlier, we found that almost half of those patients had platelet counts of less than 20,000 at less than 24 weeks. Also, when we looked at the breakdown of the kind of cases that we were seeing, 90% of them were immunized to the HPA-1a antigen. The other 10% were to a variety of antigens. So far and away, the most common cause of the problem was HPA-1a, and unfortunately, that caused the worst disease. The initial fetal platelet, the median initial platelet count in that group was less than 20,000. So the conclusions from the natural history study was that, and there's a lot more data that I'm not sharing with you, but it is that this disease typically causes severe thrombocytopenia early in the onset of the fetal course. I didn't show you this data, but it worsens or remains severe as gestation progresses if you don't treat it. It's often more severe in a subsequent sibling when compared to the prior one, and it appears to be much more severe in cases of HPA-1a than in the other causes of this condition. Now, another thing that we found early in our experience with this disease was that a requirement to be in any of our studies was that you had to have an at-risk couple, and then you had to do an initial platelet count to see if in fact that was a patient that was eligible to be treated. And what we started to hear were reports around the country of fetuses that were dying as a result of the initial blood sampling procedure. These were patients who were at risk for the disease, had been given no therapy, they had their initial PUBs or fetal blood sampling procedure, and the fetus died in utero before there was any treatment. So we decided to look at some of those cases, and we had 8 cases in which that occurred, and we compared the data that we had on those patients with 44 affected controls who underwent the exact same procedure, but who didn't die after the initial blood sampling procedure. Okay, so we then we looked at the 8 cases, and 5 of them were clearly due to exsanguination. And we know that because the person who did the pub said, I stuck my needle into the fetal vessel, I got my sample, I pulled it out, I saw streaming that was coming from the puncture site, and it just didn't stop, and the fetus died. There was one case that was due to chorio following the procedure. There were two cases where the cause of death was unclear, but the fetuses died in both cases within 2 days of having done the procedure. So we then decided to look specifically at the 5 cases that were due to exsanguination. All the sampling was done at approximately the same time, but the mean fetal platelet count in the group of 5 fetuses that exsanguinated was substantially lower than that in the group that didn't. All of them had initial platelet counts of less than 20,000, and 4 of the 5 had initial platelet counts that were less than 10,000. So as a consequence of that, we recommended that whenever fetal blood sampling is done in a patient that is at risk for this disease, that you have to be prepared to deal with the consequences of severe thrombocytopenia at the time of the pubs. And just a word about that is that what you need to remember is that when you're doing a pubs and you remove the needle from the puncture site, the fetus has to be able to plug that hole in order to not exsanguinate. And what we're interested in doing is just having a high enough platelet count when we pull that needle out so that that hole gets plugged. We are not treating the disease with the platelet transfusion that we do in order to avoid that, because the half-life of platelets is so short that it's not going to last for any substantial amount of time. But the objective is to just get away with doing the pubs safely. So in order to do that, what we said was get antigen negative platelets ready at the time that you do the fetal blood sampling procedure. And the best place to get that is from the mother. The mother doesn't have the antigen on her platelets. That's what's the cause of the problem. So if you take her platelets, they spin them down, they wash them gently. You can't wash platelets too vigorously because that deactivates them, and just have them ready for transfusion. Then when you do the pubs, you have the ability, you must have the ability to do essentially an automated CBC right at the bedside of where you're doing the pubs. So what we do is aspirate a sample of blood, get the fetal platelet count, and with the needle still in the vessel, determine whether or not the patient needs to have a platelet transfusion prior to withdrawing the needle. And if the platelet count is less than 50,000, we simply give the the spun down concentrate of maternal platelets right through the needle into the vessel, and then we can pull it out. And having done that, we know of no case of a fetus that has exsanguinated when doing fetal blood sampling for this disorder. Okay. Our second randomized trial was done a number of years later, and we at that point had learned that the single biggest risk factor for the severity of the disease is whether or not the prior affected fetus had an intracranial hemorrhage. So we looked at our lowest risk patients, who are patients that had no antepartum intracranial hemorrhage, but did have an intracranial hemorrhage, either delivered a baby that never had an intracranial hemorrhage, or where there was an intracranial hemorrhage that was first discovered in the NICU. And we included those patients in this lowest risk group because we weren't sure whether or not those intracranial hemorrhages discovered in the NICU were caused by a vaginal delivery that shouldn't have been allowed, as opposed to an antepartum intracranial hemorrhage before the onset of labor. So we had almost 80 patients that we broke down into two categories depending on whether there was one group had a neonatally determined intracranial hemorrhage, and that group also included fetuses that we found on our initial blood sampling to have platelet counts that were less than 20,000. And the other group were patients that had initial platelet counts that were greater than 20,000, and there was no intracranial hemorrhage in a prior pregnancy. So our protocol was to do the blood sampling prior to therapy, check it again 4 to 6 weeks later, and prior to delivery if the patients wanted to deliver vaginally. And I'm not going to give you the details of the study, but just to tell you that what we found were several things, one of which was that in this group of relatively low-risk patients, these were people with no intracranial hemorrhage in a prior pregnancy, or one that occurred so late that we weren't sure if it occurred in the intrapartum period or perhaps in the nursery itself. A quarter of these patients had initial platelet counts that were very, very low, less than 10,000. So what we concluded from this study, without going into the details of it, was that if you treat with this group of patients with IVIG at the standard dose, and I put that in quotes, of 1 gram per kilo per week, it's not enough for a significant number of the fetuses. People who have mild disease can be successfully treated with less intensive therapy, but those who are severely affected will need more than 1 gram per kilo per week. So that was valuable information. However, it all came at a cost. This study was published in 2006, and what you should all be aware of is that there were a heck of a lot less fetal blood sampling procedures being done in the United States then than when we started all of this. And the reason is that the major reason that fetal blood sampling was done in the 80s and 90s was to treat Rh disease. But with the advent of ROGAM, Rh disease pretty much disappeared. It still does exist, but in much, much lower numbers than we had seen before. And as a consequence, people around the country lost their expertise in doing fetal blood sampling, and younger folks had really not amassed much experience at all. And that was true not just in the United States, but around the world. And so what we were seeing were problems associated with the fetal blood sampling, not the exsanguination done in the very early cases, but trouble later in the pregnancy when we were checking to see how we were doing with the therapy. And in this series, and remember, these blood samples were done all around the United States, in many cases, in the place where the patient was getting her obstetrical care, rather than traveling to centers that had a lot of experience with this. In this series of 79 patients, there were 11 serious complications following a total of 175 PUBS procedures, or 6%. And it resulted in emergent delivery or death in utero of 14% of the 79 cases. So the information that we got in this second randomized trial series came at a significant cost. So we designed our third study, randomized trial, to try to figure out if we could treat learning the lessons that we had learned in our earlier work by minimizing the amount of blood sampling that we did. And so this third study was designed to do that. We did decide to use fetal blood sampling to see if, in fact, we needed to add more therapy in the third trimester. But we did our first blood sampling, ideally, at 32 weeks or later, because we thought that if we got into trouble with fetuses that had a bradycardia, and needed to be delivered emergently, that if you deliver a fetus at 32 weeks, particularly if you've given steroids beforehand to enhance lung maturity, that those babies were unlikely to get into major trouble as a result of premature delivery. And that was the major problem that was occurring with blood sampling around the country. So we decided to not do blood sampling until 32 weeks. And again, now we are dealing exclusively with a population of patients that had no history of intracranial hemorrhage in a prior pregnancy. And the reason we eliminated those neonatal intracranial hemorrhages was because there was no way, based on this protocol, that we could differentiate them from the ones that didn't have the hemorrhage in terms of what their initial platelet counts were. So entry criteria was you had to have a fetus that was at risk for the disease, but no ICH in a prior pregnancy. So we had 73 patients. We randomized them to receive either IVIG at 2 grams per kilo per week or IVIG at 1 kilo per week plus prednisone and a half a milligram per kilo per day. And we empirically started these people on treatment at 20 weeks, no blood sampling. We did our first blood sampling at 32 weeks after giving betamethasone for prophylaxis for fetal lung immaturity. And if we found that the platelet count was very low at 32 weeks, we empirically raised them to full therapy, which I'll mention again in a second. Or if the patient didn't want to have fetal blood sampling or at 32 weeks, or the obstetrician felt that it was technically too difficult to do it, we put them on salvage therapy. And salvage therapy was IVIG 2 grams per kilo per week plus prednisone at a half a milligram per kilogram per day. So that's what this study was. And what we found was that either of the two initial approaches to therapy were equally efficacious. Neither was superior to the other. They both worked just fine. And finally, the last thing I'm going to say before I tie this all together and really give you the money slides on how to take care of these patients is to talk to you very briefly about all of those patients that did have higher risk pregnancies because they had a fetus that had an intracranial hemorrhage in a prior pregnancy. And over 14 years, we took care of 37 pregnancies in which that was the case. There were 8 patients that what we termed as having extremely high-risk pregnancies, which meant that they had an intracranial hemorrhage in their fetus in utero prior to 28 weeks. Very high risk, 17 cases where there was an intracranial hemorrhage occurring between 28 and 36 weeks, and high risk, which were 12 pregnancies in which there was a perinatal intracranial hemorrhage. We started these patients on empiric therapy not at 20 weeks, but at 12 weeks. And we did blood sampling at 20 to 22 weeks and augmented their therapy as appropriate. And some, but not all of those patients had blood sampling performed 4 to 6 weeks later. And so the recommendations that I'm about to give you are based on those studies. So here are the money slides. This is why those of you who are still awake turned in to hear this talk, presumably. What do you do when you have a patient at risk for this disease? Well, first of all, who's at risk for it? If a patient comes to you who is a multiparous patient, and when you take your history, you are told that that baby had thrombocytopenia, you want to know whether or not they think they know why that occurred. And any patient who tells you, well, the baby's platelet count was low and they really don't know why, that's one patient that needs to be tested. Another is any patient whose fetus, whose neonate, had an initial platelet count of less than 50,000, regardless of why they think that was the case. even if they think it was due to infection or some other condition, they need to be tested for alloimmune. And any fetus that has an intracranial hemorrhage in a prior pregnancy of uncertain cause, those are people who should be tested for alloimmune. And the first thing you do is find out if the mother is thrombocytopenic. If she is, then she needs to be evaluated by a hematologist. She's at high risk to have ITP or some other reason for maternal thrombocytopenia, and she is not likely to have alloimmune thrombocytopenia, although occasionally there are patients who actually have two conditions. But the patients that are typical are those that themselves have normal platelet counts. And from them, you do your testing for alloimmune. And it's very important for you to know that this testing cannot usually be done in your local labs. These have to be done, these are very sensitive tests, and they really should be done in regional or ideally nationally recognized platelet study labs. The one that we have used for all of our studies from 1983 on is the Blood Center of Wisconsin in Milwaukee. And I have no personal financial connection with them, but for my money, that's the best in the United States. There are several other really good platelet labs, but you cannot send them to your local lab and expect to get meaningful results. What needs to be done is both the mother and the father of the affected child need to have platelet antigen typing, and you need to see if the mother has antibodies to the antigen on her husband or the father of the baby's platelets that she doesn't have on hers. And the diagnosis of alloimmune is summarized on this slide. You have to have an incompatibility between the mother and the father's platelets on one of the 2B3A platelet complex. And again, the major one is HPA. And the classic setup is the mom's HPA 1B, 1B. The dad either is a homozygote for HPA 1A or is a heterozygote for it. And the mother has to have circulating anti-HPA 1A antibodies. That's how you make the diagnosis. Then, when you've done that, you now have the patient pregnant with the next pregnancy. What do? Well, if the dad is a homozygote, then you have an obligately affected fetus. Now, notice that I say the father and not the husband. That is not necessarily the same human being. And if there's any question, assume that the father is a heterozygote. If the father is a heterozygote, what you need to do is determine whether the fetus inherited his HPA-1A or his HPA-1B gene. And the way you do that is by amniocentesis, not CVS. The reason you avoid CVS in these patients is because that increases the potential for introducing fetal platelets into the maternal circulation, and it's best to avoid doing that if you can. So if the fetus is negative for the HPA-1A antigen, you're done. That's not a fetus at risk for this problem. But if the fetus is antigen positive, you have to treat the disease. So how do you treat the disease? Okay, if there is no history of an intracranial hemorrhage in the prior pregnancy, our current recommendations for therapy, and I do not think they're going to change, are as follows. Starting at around 20 weeks, you empirically treat these patients with either IVIG at 1 gram per kilo per week plus prednisone at 0.5 milligram per kilo per day, or IVIG 2 grams per kilo per week. Then when you get up to 32 weeks, what we were doing is offering fetal blood sampling. But now, in the lion's share of cases, We simply assume that we haven't gotten an adequate response to our therapy, and we put them on salvage therapy empirically. We give them IVIG. We increase their IVIG to 2 grams per kilo per week if they had been on 1 gram per kilo per week and continue the prednisone, or we add prednisone if they had just been on the 2 grams per kilo per week. We deliver these patients by 37 to 38 weeks after documenting lung maturity, and we only recommend doing a vaginal delivery if you've done fetal blood sampling and know that the platelet count is greater than 100,000. The overwhelming majority of patients will say, I'm happy to have the cesarean. I don't want to take any risks associated with the fetal blood sampling procedure. There are patients who want huge families. We've got lots of Orthodox Jewish women in New York who want big families. We don't want to have to do 10 or 11 cesareans. So those are patients that we would like to do fetal blood sampling on. But that's a very small number of patients. The rest are people who have had intracranial hemorrhages at less than in a prior pregnancy. If it occurred at greater than 28 weeks, we start treating them at 12 weeks with IVIG at 1 gram per kilo per week. When we get them to 20 weeks, when they get up to 20 weeks, we either increase it to 2 grams per kilo per week, and we add prednisone at 0.5 milligram per kilo per day. And then when they get up to 28 weeks, we put them on full salvage therapy. The most severely affected are the ones who've had an intracranial hemorrhage at less than 28 weeks, and these are tough patients to treat. We start them at 12 weeks on 2 grams per kilo per week of IVIG, and when we get them to 20 weeks, we put them on we add prednisone at 1 milligram per kilogram per week as opposed to 0.5 milligram. This is a lot of treatment, and these patients do have side effects. But we have had extraordinary success with this this group of very, very high-risk patients. We recommend delivering any of the patients on this slide at 35 to 36 weeks after documenting lung maturity, and we only recommend delivery vaginally if you have documented a platelet count of greater than 100,000 with fetal blood sampling. So that's where we stand right now. Now, I said I had 2 objectives, and I don't have a lot of time left, but the second objective was to talk about research that's outside the typical way of getting an NICHD grant to do your research or participating in a pre-formed network of people studying a specific problem, like the perinatal research division of the NICHD, that is a group of institutions that work together on common protocols. What was unique about the work that I've just described to you is that this was a study of a relatively rare disease by recruiting patients from a very large catchment area. It was literally the entire United States, and we had patients from Canada and some from Europe as well. It was a series of national or international studies, in fact, without any kind of significant external funding or utilizing a preformed network of investigators. We didn't get any grant support for any of these studies. The only financial support that we got was the manufacturers of the IVIG that we used in our patients, whether they were in New York or anywhere in the country, was given at cost to the patients in our studies by the manufacturers of the IVIG. They just agreed to accept whatever insurance that the patient had, and they accepted that and had didn't require any additional payment for it. Thirdly, this was an investigation that was a collaboration of 2 people that were working in competing medical centers in New York. Dr. Bussell was at Cornell. I was at Mount Sinai. I am now at Columbia. We compete for patients in those two institutions. But the two of us created this collaboration, which has lasted for more than 30 years and made possible the studies that I have been sharing with you. The fourth thing is that because we were working together on the same problem for so long, we learned from the mistakes and the information that we got from each of our studies in order to modify what we were advocating in a way that made the next study more meaningful in terms of moving towards an achievable objective. And finally, this has led to the development of a diagnostic and therapeutic approach, which to our knowledge is literally the first non-invasive cure of a potentially lethal fetal disease in utero. And I personally hope that what we can anticipate over the next 30 years are many more achievements in this category where we're not having to stick needles or trocars or laser instruments into the uterus, but can treat these things, fetal conditions, medically, and in some cases to literally cure the disease. Work remaining to be done. One, we don't currently screen for this disease. It's not cost efficient, but it would be great if we could look for people who are at risk for this disease before they have an affected child, which is the way that we currently find them. The second thing is, it would be very nice if we could develop the platelet equivalent of RhoGAM. And there is a European company working on this right now, and at least some of these cases could be avoided if we couple this with the screening that I've alluded to in the first bullet here. And the third thing is to isolate the active ingredient in IVIG for managing this disorder in cases that we can't prevent. Because there will be failures to platelet equivalent of RhoGAM if we ever get there. And there are some patients who are going to get sensitized, we can even give that. So knowing how to treat this with something that's less or disease would be a giant step forward. And that's where I hope we will end up. So thank you all for listening. Can you tell me what the current therapy is? Is she on 2 grams per kilo per week of IVIG? I'm not hearing anything. I'm hearing you, Bill, but I'm not hearing anybody asking the question, and I'm not seeing it written. I'm not seeing that typed in question. I'm seeing the box, but there's nothing in it. I'm hearing you, so why don't you tell me what the response to that was? What is she currently being treated? Well, okay, so if we don't know what she's being treated with now, let's assume she's on 2 grams per kilo. She doesn't want to take prednisone. She has two choices. First of all, on 2 grams per kilo per day, per week, she's highly likely to have a good response. And so she can refuse the prednisone. I would definitely want to deliver her by cesarean and not by a vaginal route. But the alternative would be to offer her fetal blood sampling just to be sure that she really shouldn't consider being on the prednisone. So that's how I would handle that. If she's only on a gram per kilo per week, I would definitely increase her to 2 grams per kilo per week. Good question. No, we don't. We really don't have data on, we don't know how to measure anything other than birth platelet count because we look at the IVIG levels in the mother and they are not helpful in terms of outcome. But we have handled a number of women with twins through the years and have not seen any significant difference in the twins versus the singletons with the recommendations that I made to everybody. So no, we don't alter the dose in multiple gestations. Two reasons why the first pregnancy can be affected. Number one, the way in which RH patients get affected is because fetal red cells get into the maternal circulation and sensitize the mother. Fetal platelets do the same thing, and they're a lot smaller. So they probably get in much greater numbers than fetal red cells do, and they probably get in much earlier. Not only that, the HPA-1A antigen seems to be more immunogenic than the big D antigen. At least clinically, it looks like that's the case. The other reason why the first pregnancy can be affected is because there's a group in the UK that has actually identified the HPA-1A antigen on trophoblasts. So this sensitization may occur really with implantation and may actually have little, if anything, to do with the amount of platelets that gets into the maternal circulation, at least in some cases. Anyway, for sure, it's different than RH disease. It's theoretical. Um, when you consider what's going on in labor, what you're doing is having the fetal head continuously abut the bony pelvis of the, the mother's birth canal. And if you've got a platelet count that is certainly less than 50,000, well, for sure less than 30,000, that is not a good idea. 50,000 is something that we use as a fudge factor, and 100,000 makes it even more liberal. So We don't have any hard data to say that this is something that makes enormous sense, but we think that in women who want to have a maximum of 3 children, having a couple of cesarean sections is not as bad a thing as having made a mistake and ending up with a baby that has a serious intracranial hemorrhage. So that's very soft, that recommendation, but that's the reason behind it. Unfortunately, none other than intracranial hemorrhage. Well, actually, they can bleed into any organ. There are, I believe, reported cases of intrahepatic hemorrhage, but I would say that any fetus that has what is thought to be a hemorrhage into a fetal organ should be evaluated for alloimmune thrombocytopenia. And you can do that by simply getting a sample of the mother's blood and the dad's blood and sending it to a platelet reference lab. But unfortunately, that's not the way you want to diagnose this disease. You want to diagnose it before that happens, if possible. That's an excellent question. Um, what I would do where all of you folks work, I would get on the phone and talk to the head of your blood bank and find out what experience they have with platelet transfusions and platelet preparations. If they are comfortable doing this, great. But if not, there are hematologic centers around the United States that they can call and find out exactly how to do it. And a very, very good reference for you all to have is the blood center, the platelet lab in the blood center of Wisconsin, which is in Milwaukee. And I'd have the people from your blood center, from your blood bank, contact either, I'm blocking her name. Uh, Jan, Dr. Jan McFarland is the head of that lab, and ask her about what they can do to help you out by having platelet preparations made for you. Jan McFarland in Milwaukee at the Blood Center of Wisconsin. The head of the lab itself is a guy named Brian Curtis. Where is what? I'm sorry, I didn't hear you. The pus. We do it in the operating room. Patient doesn't have to be admitted, but she can be a day of admission. She can go home the same day, but we do the blood sampling in the delivery in an operating room because we're not doing our platelet. We're doing our blood sampling these days at 32 weeks or greater. And if we get into trouble with a significant bradycardia, we would like to be able to deliver the patient. That's why we give them steroids before we do this. It is an outpatient procedure if you have a non-viable fetus to work with. If you're doing this at 24 weeks, you don't have to do it in an operating room. But if you're doing it with a fetus that you think will live, if you pull it out and send it to the NICU, it should be done in the OR. Um, if I got uh, if I got back a result that said the lungs were not mature even if it was at 36 or 37 weeks, I would just empirically give a course of steroids and deliver her. If you don't want to do the amnio, I don't feel very strongly about this, but you certainly could give steroids under that condition or situation, or alternatively wait until the interval between 37 and 38 weeks. Quite honestly, the problems these fetuses have almost never have anything to do with prematurity, unless you've gotten into trouble with the pubs at 28 weeks and have to deliver the baby then. Thank you, Bill. Bye-bye.